Mr. Chairman, Mrs. Chairman, Chairwoman, ladies and gentlemen. It's a true pleasure for me to be here today. And I will give you some insight about interventional cardiology and acute coronary syndromes. So what happened at the ESC Congress was a really hot Congress. The slides were presented by Yulinda Mehili from Munich and Dr. Lettino from Milan. So the first study I would like to discuss with you is the SYNTAX-2 study. You may remember the SYNTAX study was a randomized controlled trial looking in patients with multivessel coronary disease randomized to coronary artery bypass surgery or PCI with Taxus stent. At the time, the surgery was found to be superior, especially in patients with high SYNTAX score, a high level of complexity of the lesion. So now the question is, now we are changing a little bit our strategy. We are not simply stenting all the lesion we can. We are trying to look for function. And on the other hand, we are also optimizing our result of stenting with intravascular imaging. And finally, our stents are getting better. So if we change our strategy, does this compare favorable with historic control of the SYNTAX study? So this is really the design of the study. This is a not randomized study. This is a single-arm registry, actually, prospective. 450 patients were included, not 315 as seen here, but 450, sorry for that, were included in the study. So IFR, so the functional relevance of all the lesion was assessed first. And if the patient had an IFR less than 0.86, then this patient underwent PCI with a synergy, a drug-eluting stent, and the PCI was optimized, used IVUS imaging. If the patient has somehow intermediate IFR between 0.86 and 0.93, then FFR was measured, and according to the standard cutoff, if the FFR was less than 0.80, the patient underwent stenting. On the other hand, if the patient has IFR greater than 0.93, or if the patient in the gray zone had an FFR greater than 0.80, the patient, let's say the stenosis was treated conservatively. So we are moving away from a SYNTAX strategy where all the significant lesions, so-called by angiography, were stented, towards a more selective approach where only the lesions which are functionally relevant are stented. Obviously, the patients were treated optimally from a medical perspective, and the purpose of the study was to compare the outcomes of this cohort of patients with the historic one, namely the PCI group of the SYNTAX study. And this is the result in terms of major cardiovascular events at 1 year, defined at all-cause mortality, revascularization, myocardial infarction, or stroke. The blue line here are the outcomes of the SYNTAX-2 patient. On the red curve are the PCI arm of the SYNTAX study. As you may appreciate, there is a superiority in the comparison with this historic control. So, one might say that according to the observed outcomes, a SYNTAX-2 revascularization strategy for multivessel coronary heart disease appears to compare favorably with the SYNTAX-1 cohort. If we look at the individual endpoints, now compared to the SYNTAX PCI group of the SYNTAX study, there were significantly less myocardial infarction and was significantly less need for revascularization. So clearly our stents are getting better, the need for revascularization is lower. However, we have to say that less lesions were treated in this study compared with the historical one. And the investigator also compared the outcomes of the SYNTAX-2 patient population with the CABG arm of the SYNTAX study. And as you see, if we compare the dotted line here, these were the outcomes of the CABG group in the SYNTAX study the result were comparable with the syntax to PCI patient. So according to this observation, we may say that the use of a syntax 2 revascularization strategy appears to give comparable result with the cabbage result in syntax study. However, there are clear limitations. This is not randomized. This is just a comparison with a historical perspective. And the sample size was limited. Obviously, there is room for larger trial looking at just treating the significant lesion and then comparing them with the cabbage population. The second study I would like to address with you is the tropical ACS study. The tropical ACS was based on the following background thoughts. The use of contemporary drug-eluting stent technology and decision-making pathways for PCI has drastically reduced the risk for ischemic events following stenting at short and long term. In addition, optimization of chronic antithrombotic therapy to increase the net clinical benefit by reducing the risk of bleeding is desirable, the so-called de-escalation strategy. So use potent platelet inhibition only at the time where you need it. So this is the design of this interesting study. So these were 2,610 patients undergoing successful percutaneous coronary intervention. All the patients received initially prasugrel. These were all biomarker positive acute coronary syndrome. But then the people were randomized to a standard treatment, so prasugrel for 1 year, which would be a standard treatment, prasugrel or ticagrelor for 1 year, in addition to aspirin, standard treatment as according to the guidance, or patients were randomized to do a de-escalation treatment. What is that? So all the patients received 7 days of prasugrel in addition to aspirin, but then they were switched to 7 days of clopidogrel without loading dose, simply going from 10 milligram of prasugrel going to 75 milligram of clopidogrel. And then 2 weeks after randomization, 2 weeks after discharge, the patient were called back and a platelet function test was determined. For the patient who were in the prasugrel arm, this did not change anything. They just continue with prasugrel for 1 year. But the patient in the de-escalation arm, if they had a good response on clopidogrel based on the platelet function test, then the patient remained on clopidogrel. And these were 60% of the patient in the de-escalation arm. Conversely, if patients in the de-escalation arm were found to have insufficient platelet inhibition on clopidogrel, they were switched back on prasugrel. So the primary endpoint of the study was at 1 year cardiovascular death, myocardial infarction, stroke, or BARC 2 or more bleeding. As you can appreciate this, the red curve was the one of the guided de-escalation strategy compared to the standard strategy in the blue column. There was a significant reduction in terms of the primary endpoint for patients allocated to the de-escalation group. And this was highly statistically significant for non-inferiority. If we look at all bleeding events, and these were secondary endpoint, or we look at ischemic events, then you see that the red curve, so the de-escalation arm, compares favorably. In particular, in this patient population, there does not seem to have any hint for an increased ischemic event rate in the de-escalation group. So the conclusion is that in this patient population, de-escalating the treatment of antiplatelet treatment appears to be safe. The second study I would like to address with you looked at the combination of new anticoagulant, namely dabigatran, in patients with atrial fibrillation undergoing PCI, and comparing to the standard treatment of triple therapy with warfarin. So the REDUAL PCI trial randomized 2,700 patients with atrial fibrillation and PCI. So all the patients had to undergo successful PCI with standard antithrombotic treatment. So in the vast majority, this may include also aspirin at the time of PCI. And then they were randomized within 5 days following the successful PCI. The patients were randomized in 3 arms. The first one, dabigatran 150 milligram per day, twice a day, plus P2Y12 inhibitors. The second arm was dabigatran 110 twice a day, plus a P2Y12 inhibitor. And the third arm was the standard triple therapy arm with warfarin, P2Y12 inhibitor, and aspirin. With respect to the triple therapy duration, and this is something new compared with other studies like the Pioneer study, for example, the duration of triple therapy was determined upfront and was 1 month for patients undergoing bare metal stenting and was 3 months for the patient undergoing drug-eluting stent treatment. So the primary endpoint was the time to first major bleeding or clinical relevant non-major bleeding event. And as you see here, on the dabigatran 110 milligram per day, twice a day, was clearly superior compared with the warfarin triple therapy standard arm. And you see a large difference in the event rates. And also the dabigatran 150 milligram twice a day was found to be superior to the standard triple therapy arm. Clearly, the non-inferiority was found to be present for both comparisons. What is also interesting is that the rate of intracranial hemorrhage, obviously the complication we fear the most, was found to be reduced in the dabigatran arms. You see here the 110 milligram twice a day, very low complication rates in terms of intracranial bleeding. The same is true with 150 milligram per day. So the two of them, this would be statistically significant. So obviously we want to see what are the ischemic events. So are we doing better in terms of bleeding, but are we paying a price in terms of increased ischemic events? And this does not appear to be the case. You see here all-cause death, myocardial infarction, stroke, or systemic embolism. There was no statistically significant difference. If we take here the combined dabigatran arm, 9.6%, compared to the standard triple therapy arm, 8.5%. So the conclusion is that in patients with atrial fibrillation undergoing successful stenting with standard antithrombotic treatment at the time of PCI, if the patient were randomized within 5 days, then dual therapy, defined as the dabigatran and P2Y12 inhibitors, was found to be superior compared with the standard triple therapy arm in terms of bleeding. The next study I would like to address with you goes on the value of high sensitivity cardiac troponin assessment in patients with suspected non-STEMI. As you might recall, the guidelines that we published in 2016, these are the 2015 non-STEMI guidelines, give a class 1B recommendation for a new algorithm with assessment of high sensitivity cardiac troponin at baseline at 1 hour. The guidelines give us the same option to have an algorithm, as already seen in the previous guidelines, assessment at baseline and 3 hours. But now we have more and more data that the assessment of baseline at 1 hour is indeed safe and effective, and this is an additional study that was presented at the meeting. Just to recall, if the patient comes in with suspected non-STEMI and has clinical symptoms, ECG and so on, that make you suspicious of a diagnosis of non-STEMI, then base it on the assessment of high sensitivity cardiac troponin, you can rule out or rule in the patient, and a proportion of patient will needs further investigation. So if the patient comes in with very low, extremely low, high sensitivity cardiac troponin, one single measurement allows you to rule out. Or if the patient comes in with low level and no significant change at 1 hour, again, you can rule out for MI. On the other hand, if the patient comes in with very high troponin, one single measurement is enough to rule in for myocardial infarction, or if you have significant changes at 1 hour, is the same. Now, the study is more than 4,000 patients in whom the final diagnosis of non-STEMI was found to be in 17% of the patient, looked again at the value of this assessment baseline and 1 hour algorithm. So what is important, that this algorithm was able to rule out myocardial infarction in 57% of the patient and rule in 18% of the patient in this cohort. But it was important is that the sensitivity in order to rule out myocardial infarction was very high, 99%, and the specificity was also high, 95%. And finally, once more, we see that patients that were ruled out have extremely low event rates at 1 year. So this shows us again and again that the assessment baseline in 1 hour using high sensitivity cardiac troponin, important with assessment that has been tested and validated, is really safe and effective. So in the interest of time, I will go to the next topic, which is the association of long-term condition. These are comorbidities in patients with acute myocardial infarction. This is a large studies coming from England and Wales, almost 700,000 acute MI patients, approximately 1/3 as the associated comorbidities. And you see here that is not a surprise. If you have no associated comorbidities, your long-term outcomes following myocardial infarction is far better than if you have comorbidity associated. And the comorbidity which have the greatest impact after correcting for a difference in baseline characteristic are chronic renal failure with an adjusted odds ratio of 1.73 and chronic renal failure 1.73 and chronic heart failure 1.87. So no wonder if you have this type of comorbidity, your outcome will be severely unfavorable. The last one I want to talk with you is what about the mortality in STEMI women? We know that there is some increase in mortality in STEMI women. And why is that? On one hand, we know they receive less reperfusion, less evidence-based treatment, but this registry looked at 8,000 patients, approximately 2,000 were women. And if we look at mortality at 30 days by gender, you see that women in yellow had really significant higher mortality compared with men. These were all STEMI patients on the left side or primary PCI STEMI patient, no difference, women have a worse outcome. But then this patient stratified for age. And I just want to show you in the lower part here, what is important is the patient were elderly. There was no difference in mortality between women and men. But the difference was there in younger women with age less than 60. Even if you correct for baseline characteristic, women younger than 60 have a significant worse outcome compared with men, even if they are adequately treated. So my conclusions, ladies and gentlemen, the decision about the optimal revascularization strategy for complex multivessel CAD should take into account age and clinical profile, but anatomic complexity, and the probability of achieving complete functional revascularization and access to contemporary drug-eluting stent. With contemporary PCI, de-escalation of long-term antithrombotic treatment, either on chronic day PT in ACS or dual therapy among selected patients with atrial fibrillation, appears to be safe and associated with net clinical benefit. The ESC assessment at baseline and 1 hour algorithm for rapid rule-out, rule-in of acute MI is safe and effective and should be extensively implemented. Patients with ACS are changing over time, and older age and more comorbidities may account for complication and a worse outcome. Younger women with STEMI have higher mortality as compared with men, even when they receive the appropriate treatment in a timely fashion. And I thank you for your attention.